Hello, and welcome to another episode of Plastic Surgery Unfiltered. I'm your host, Dr. Armando Davila, joined by Dr. David Turer, my faithful co-host. How are you today?
Great. Good morning.
And this, as always, is a podcast at the intersection of healthcare, business, and the beauty industry. Today's topic, why big implants are out and how technology is reshaping breast augmentation.
Yeah, this is something I'm really excited to talk about.
This is a great topic. So I'll give us a little primer here, okay? And I got to say to the audience, guys, if you are considering breast augmentation, you should watch this episode in its entirety. It's highly, highly recommended. Even if you're not coming to us for breast augmentation, it's going to be a great episode. So, so Dave, I mean, breast augmentation has been around 60, 70 years or so.
Yep.
And so, a lot of the objectives of breast augmentation have really reflected the technology, right, available, I think, at the times. And, in particular, I think a lot of people who still get breast augmentation of all generations see breast augmentation as the 90s aesthetic, right? Large, round, unmistakably augmented breasts, and the this obsession with are these fake, right? And the movement now is to sort of this very natural, sort of undetectable breast.
Right. A lot of people want a much more natural look, and I think it's probably going to be helpful for us to talk maybe a little bit about the history of breast augmentation.
Yeah,
I mean, I don't know that we need to get into all of the specific details, but at least talk about the global changes that have occurred and how the technology has allowed that evolution.
Yeah, let's go for it. I mean, the reason we're having this conversation is really important, right? A global study of about 18,000 women.
Yeah, about 18,000 women, I think, from about 40 countries.
40 countries, right? They surveyed women about satisfaction with their breasts. Only about 30% were satisfied. And the remainder, 50%, wanted larger breasts.
About 20% wanted smaller breasts. About 50% wanted larger breasts.
And yet only about 4% of women in the world have breast implants. So of that 50%, there's sort of this disconnect. And yet when women get breast implants, they are
overwhelmingly satisfied.
like 95%, 95% satisfied.
Well over 90%, 95% satisfied.
So the question is, why is there a disconnect, and what is keeping women from pursuing something that will bring them satisfaction? And you could say cost, I guess, is
Sure.
a big one, but breast augmentation is not it has a pretty good rate on return.
From a safety profile and from a satisfaction standpoint, I mean, there's no question that it's a great procedure.
Yeah.
But I think, like I said, the history of breast augmentation is filled with concerns and, frankly, problems from some of the older technology. And I'm sure that some of that is carried into the modern age.
Sure. So yeah, I mean, we can go over. Where do you want to start? Do you want to go with Cronin and Giroux all the way back there, or do you want to pop into?
I think just as kind of a broad perspective. So when plastic surgeons first started doing breast augmentation, the implants were not great. They were typically done above the muscle in a subglandular position. Many of those patients had complications like capsular contracture. Over the course of decades, the technology improved and the techniques improved, but the technology didn't improve to the point where that above the muscle subglandular augmentation was still acceptable. And so then a lot of plastic surgeons moved below the muscle.
Yeah, I mean, but can you talk about what were the technological issues that made
Sure.
that be possible?
Sure. I mean, the materials themselves were a big problem. There were even, now we use silicone, but there were even polyurethane implants at one point, which we found caused a lot of problems. For example, in the early silicone implants, there were things like gel bleed. And so you have a solid shell and gel that's on the inside, but the shell would not contain that gel. So it would diffuse out, which was highly inflammatory and would lead to things like...
Yeah, because it was like a liquid, right?
Yeah.
It was like a liquid substance.
Capsular contraction.
And so you'd have this and I think that people, still, and unfortunately, there are still discount kind of level breast augmentations occurring with these very, not as old as gel bleed, but but very liquidy kind of implants that still can cause extracapsular rupture.
Yeah, I mean, I think that most people, or pretty much anybody that's doing breast augmentation these days, are at least using a Gen 4 implant, the older, less cohesive implant. So it's still, I mean, if you want to consider it like a solid, it kind of is, but it's not nearly as cohesive, or the gel is not as solid as the modern implants are.
I mean, the Gen 4s are pretty liquid. I mean, they're pretty runny, and they don't have gel bleed issues per se, but
So for some perspective, the way that they corrected that, so basically the way that they make the shell for these implants is they dip the template, it's called a mandrel, into the silicone and allow it to cure and harden. And then at some point in the process, they dip it into a different formulation that's much denser. And so it stops the smaller molecules of gel from diffusing through the shell.
Yeah.
So once they figured that out, that barrier layer, it prevented gel bleed.
Yeah, and those were the implants that were banned in the U.S., like the third generations were the ones that were banned in the U.S. in the 90s. Then, saline implants kind of took over. And I think that that's why in the 90s you did develop this sort of round implant look, because you basically only had saline available and you lost a lot of the natural look.
Well, and I think it's important to talk about why that happened. So there was concern at the time that the silicone gel breast implants were causing things like autoimmune disease, which, fast forward multiple decades later, and there's still discussion about that despite good evidence that they don't. And so there was a period of time where the silicone gel breast implants were taken off the market to make sure that they were safe. And at that time, the only thing that was available were the saline implants. Mm-hmm. And one of the major issues with a saline implant is rippling. Mm-hmm. Unless the implant is completely filled, and in fact overfilled to its nominal capacity, so it's tighter than heck, you're going to see rippling, and it tends to look pretty unnatural. And I think that was one of the things that led to that look in the 90s.
Yeah, I mean, I think that one of the other problems is that, when you have larger implants, larger of any size, anything that's a larger, heavy implant, it's going to rely on some of the structural components of the muscle in order to provide that, what we call soft tissue support, right? Sure. And so, as we move away from that idea, we move into smaller breast implants, not only is the technology advancing, but we're also kind of moving the needle that requires that kind of submuscular approach in some senses.
Sure,
So,
absolutely.
Was there anything else you had about?
No, I mean, silicone gel breast implants came back on the market in the 2000s, and over the last 25 years, there have been huge advancements in the technology. Now there's 4 manufacturers. Most recently, Motiva was approved in the U.S. about 2 years ago, and they've incorporated some new technology into the implants. Things like the shell that has, in theory, a lower rate of capsular contracture, and the monoblock construction. There's a variety of things that are probably improvements over some of the other implants. But I think in addition to that, there have been huge improvements in technique, whether we're talking about above the muscle or below, that have really decreased the rate of complications.
Okay, we'll get into that in a second, but
Sure.
I have a question for you, okay? Are the surgeons the ones who are responsible for the fake implant look, or did the patients basically ask for that, and that's what they were responding to?
I think that it was a result of the technology from the time. I think that by the virtue of the fact that that's what we had, and that's what people got, so that's what people saw, and that's what they wanted. And it took quite a long time for people, the pendulum to swing away from that towards what we see now, which is a more natural look.
Okay, but patients come in, and we have this happen to us all the time. They say they want a natural look, a natural result, and then when we do their 3D simulation,
they choose like a wildly unnatural looking implant.
They choose a naturally looking implant. So again, why are still some surgeons doing these very large implants? Why are patients still choosing this sort of unnatural look if they say they want in, they want a natural look?
Well, I think we're kind of generalizing, right?
Mm-hmm.
We're saying that in general, people want a natural look, and that's not totally fair, right? Because there are some people that do, there's some people that don't. And I mean, I think that's one thing that's really important, is being able to personalize the result to the individual patient's desires.
Yeah, I mean, I personally think that, again, if people are thinking about breast augmentation, they ask their friends, they look at photos, they do all this sort of stuff and research, and what you see is a relatively unnatural look in most of the catalogs, right? Because they're historical.
And because the ones that look very natural, you don't know that they have a breast augmentation.
That's correct.
And so that's kind of like a little bit self-selecting. So again, the people that, maybe that 4% of women have seen the women that look augmented, that's more obvious they have a breast augmentation, that they have implants, and so they gravitate to that. But maybe that 50% of women that are out there that are unhappy with the size of their breasts, that maybe want something like a cup size bigger, they may not know that some of their friends even have a breast augmentation, and that's a possibility for them.
Yeah. And so I do think that these augmentations where it's almost imperceptible is really the kind of movement that is happening. And I've always had a penchant for this. And one of the ways that I've had to solve this problem previously is really through fat grafting, right? And so people come in, they want fat grafting. I can do small volume, small augmentations that kind of really add some small volume to the breast and maintain a very natural look. Again, and I don't think it's hard because not every person's a candidate. Number one, it's laborious, it's typical, it's expensive, and some people don't have the fat on them.
I mean, I think that's the issue, right? Like, I think that a lot of people come in and they want a breast augmentation with fat grafting, but they don't realize the technical limitations of that operation. There's a limit to how much fat we can put in. I think people assume that you can just put as much fat in as you want and that it will survive. It won't.
It won't. Yeah.
There's a specific limit as to how much fat we can put in. So that often means that for a more significant augmentation, and there's certainly a limit as to how much of an augmentation you can get, you're often talking about multiple rounds, sometimes 2, 3, or more rounds of fat grafting to get an acceptable result, which for a lot of patients is not an acceptable amount of cost and downtime.
Yeah, exactly. Yeah, I mean, it adds a certain amount of risk also at area like risk in the donor site where we're getting the fat from, and so there's a lot of other stuff that goes into it.
Well, and I think people assume that because it's natural that there's no risk to the breast, but that's not true, right? We know that fat grafting doesn't increase your risk of breast cancer, but it does increase the risk of visible lesions on things like a mammogram that require additional interventions like a biopsy. And so, there are trade-offs as well.
Yeah, absolutely. So then if there's this, again, why do you think, we talked a little bit about this, that if 70% of women are not happy with their breasts, why are only 4% getting implants?
Well, I think it's multifactorial. I think a lot of people are scared of cost is certainly some factor, right? Like there is a cost associated to having plastic surgery, but I don't think that's the major barrier. I think most people probably don't know what the options are. I think when most people think about breast implants, they do think about the Pamela Anderson look from the 90s, and they're like, that's not really what I want. So they may not even know that there's a lot of women that are running around with very natural looking breast augmentations, and that is a possibility for them. They may want to avoid, the downtime, or they may not understand that, you can get back to life pretty darn quickly after surgery with the appropriate protocols and techniques.
Yeah, I mean, one of the things that we've talked about several times on the show is the NOVA protocol, right? Yep. And again, we continue to shorten our recovery times. I mean, breast augmentation at this stage has basically a day of recovery, 2 days of recovery, and especially with some of the above muscle techniques, you could be looking at, going back to work and life very quickly without kind of any significant functional downtime.
I think people, again, and we've talked about this multiple times, is there's a difference between activity restrictions and downtime. Like most people could probably be out to dinner the night of their breast augmentation.
Yeah.
Right. I mean, it's just not. I mean, we all know guys. We talk about there's, I trained with guys that talk about the rapid recovery breast augmentation, where that's the expectation. Yeah. And we use a lot of the same techniques. I mean.
Yeah. I mean, so I don't know. So then I guess the next question I have for you is, let's talk about sizing, right? Because I think this is going to be, if patients are really moving to more natural results and smaller implants, what do you think is the big, major paradigm shift with sizing and biodimensional planning? And can you tell the audience kind of what that is?
Absolutely. So I think a lot of patients come in and think of sizing in terms of cc's, the volume of the implant, but I think that's the totally wrong way to think about it. What we do is we have to think about the base width, how wide the breast is. And we're going to get into some of these new techniques, which actually change the way that we measure those diameters. But by respecting the native footprint of the breast, if you want to talk preserving those anatomical structures, by respecting those anatomical borders of the breast, that is how we start to produce a more natural look. Then obviously breast implants have different profiles, meaning how flat or round the implant is. And so to get the desired volume, how big of a breast you want, the width is not what you adjust really, it's the projection and the profile of the implant that we choose. And so, when patients come in that are tiny, very narrow chested, and they're like, I want a 400 cc implant, you're like, they don't even make one that is anywhere close to appropriate for you. Yeah. It will give you a ridiculous look.
And I think that's, one thing that we'll get into our training with Dr. Mark Epstein in a second. But one of the things he was telling the patient as he was remarking is that, if you get this implant that's larger, you may be able to pull it off right now, but you're going to pay for it later, right?
Yeah.
And this is back where the technology is changing and has met some of the structure, right? You had these subglandular augmentations, you had these very large augmentations, and what would happen is the implant would essentially act as a tissue expander. And we know that when you have a tissue expander-based behavior in the breast, you get thinning of the breast tissue, you get, increase in vascularity, right? You get all these other kind of like undesirable secondary effects. And so I think this is the number one most important thing patients who are getting breast augmentation need to understand, which is where your breast was born, like where it is on your chest is your breast. And if you want to augment that breast, right, just think about the word augmentation. You can make that breast bigger, right? Mm-hmm. But the minute you want to change the structure, the appearance, not the size appearance, but the
footprint of the breast,
footprint or the fundamental.
Right. Like the perfect example is the women that come in, that have relatively low breasts, meaning they're set relatively low on the chest, and they say, "I want an implant that's right under my clavicle." Yeah. It's like, in order to achieve that, we have to do something that is grossly extra anatomic.
Exactly. Extra anatomic. You are modifying where that implant is in your chest space. By definition, that is going to create an unnatural look. And it may be what you're going for, but A, it's going to be difficult. B, it likely is going to be expensive. And if you don't pay for it in cost, you'll likely pay for it in complications down the road, right?
Absolutely.
And the big problem is that you see a lot of discount surgeons who kind of just say, well, you can throw any size implant into anybody, and those are the disasters that we see as kind of secondary and tertiary implant surgeons in the city. Yeah. And it also is what has made these implants look so fake and look so bad and scares so many people thinking that is the norm. That is normal.
Yeah,
right?
I think you hit it right on the head. And also, it's because those patients are the most visible because they're the most obvious.
Yes.
Right? So when you see them out in the world or you see them on social media or on TV or wherever, you're like, oh, that person obviously had a breast augmentation. You're not thinking about the 10 other people you may have seen that you have no idea.
You have no idea. And the reason that those people who you'd have no idea have pulled that off is because they have respected the boundaries of the breast, right?
Yep.
And I think that a lot of things that you see on the internet that fight this, right? Like the comment, if I go bigger, I won't need a lift.
Right.
What do you think about
that? It's ridiculous. It's ridiculous. Like, I don't even know what that means.
Yes.
It's funny because you and I have talked about this many times offline, but a breast lift is a total misnomer because the breast lift does not lift the breast.
Correct.
It lifts the nipple.
Correct.
On to the normal position in the breast and then repositions the rest of the tissue.
Yes. And so again, if you want to lift your breast footprint, you want to move the breast higher up on your chest. A, it might be impossible based off your anatomy. And B, you can kind of do stuff to make it look that way and make it very artificial looking. Again, you will likely pay for that in the future.
At some point.
And again, those are very expensive fixes, very expensive surgeries, and they require, very complex maneuvers.
Right.
And you shouldn't take those lightly. But yes, a breast lift is not a breast lift. It is a nipple lift. It is a moving the nipple up.
Right.
And
it's a nipple lift and breast reshaping.
Exactly.
Yeah.
And so going bigger, right, it may fill some of that loose skin temporarily, but the skin remains loose and will stretch, and that implant will just settle right into its new position.
Right.
So, but I do think it leads women down this path of larger implants, which again fights kind of the structure,
right?
The natural structure.
Respecting a more anatomic. I don't want to necessarily say reconstruction, but like rejuvenation, as opposed to this extra anatomic augmentation.
Okay. Yeah. Okay. What about another thing? All my friends say they had wished they had gone bigger after their augmentation. Why does that happen?
Again, I think it really depends on the planning. That is not something that we typically hear. I think because we take a lot of time to allow the patient to choose exactly the look they want. Mm-hmm. There's published literature on this, right? So using the systems that we use with 3D imaging, we also then, confirm with sizers in the office. Like, there's a variety of things that we do to make sure that people are getting the look that they want. It baffles me still that patients come in and are like, I didn't get to choose my size. My surgeon just said he would do what he thought looked good, which to me is baffling.
Yeah, I mean, but the other problem is the ABC cup size thing, right? And so these surgeons get told, like, I hear this from patients. The patients will go, well, I want it to be a C, and the surgeon just sort of picked an implant. And how there's, again, no major corollary between implant size,
I mean,
CC size.
I flat out tell people, I'm like, I can't, if I promise you a cup size, I'm guaranteed to be wrong, right? Because if you go to different stores, you're going to get different. We've said it on the podcast before. If I know I sound like a broken record. I've got my spiels, but like I'm guaranteed to be wrong, because if you go to Victoria's Secret, you're probably going to be 2 cup sizes bigger than somewhere else. So I'm guaranteed to disappoint you depending on the store you go to. Mm-hmm. It's the worst way of choosing a breast implant.
Yes, and so again, we give the patients the autonomy. We make sure that they get to see multiple modalities, both physical implants on their chest, within closing, within the bra, and digital, like nude-based 3D simulations. And so you can get a good thing. But again, I think that pushes the envelope towards sort of larger surgery. Right. And so I want to work backwards now from kind of the traditional approach, right? You trained in sort of not traditional, the kind of Tebet style type of breast planning. Again, a submuscular approach. And what do you think are those advantages, and why do you like to use those?
Yeah, sure. I mean, in my mind and my hands, I still prefer a submuscular dual plane approach for a number of reasons, and I think that I choose that as a default because it fits most patients well. Having the muscle in the upper part of the breast allows for good soft tissue coverage, so it camouflages the implant. So I think in a lot of patients that don't have good coverage, it provides a more natural looking approach. The muscle probably does support the implant to some degree. And, to your comment earlier about, having an implant that causes drooping, breasts age differently depending on where the implant is. When the implant is under the muscle, supported by the muscle, the breast tends to droop off of it. Whereas when it's in the subglandular space or prepec space, the implant tends to kind of sag with the breast. And so the breasts age a little bit differently. With the older implants and the old techniques, part of the reason that we went to submuscular augmentation was because there was a much lower rate of capsular contracture. Now, you could argue that with modern techniques and modern implants, that the rates are pretty similar between prepec above the muscle and below the muscle augmentation. Mm-hmm. So I'm not sure that that's necessarily a reason to choose one or the other. The other thing is that with the older submuscular techniques where there was significant release of the muscle, you saw a lot of what people would call an animation deformity. And so what that is the muscle rolls up very high, creates a band of muscle. So when the patient flexes the pec muscles, it creates really weird deformities of the implant that were visible. But with the way that we do kind of preserving more of the natural anatomy and just releasing a little bit of the muscle, we see much less animation.
Yeah, I mean, you again, this was back to our discussion of if I go bigger or I won't need a lift. A lot of surgeons with the dual plane approach, again, popularized by, Carly, help me out here. Is it, which influencer was half under the muscle?
Oh, Kylie Jenner.
Kylie Jenner, okay. With, again, this kind of,
which, just so everybody knows, half under the muscle means a dual plane submuscular.
A dual plane submuscular, which is fine, but it's not literally half under the muscle. If you had an implant half under the muscle, you'd have wild animation,
right?
And it would look awful. And so, again, a lot of these surgeons would do these very aggressive releases to do these aggressive dual plane augmentations to quote unquote avoid a breast lift.
Right. Like just to clarify why you would do that. So basically, the muscle kind of prevents the implant from stretching the tissue as much. So by releasing more of the muscle, it allows the implant to stretch the lower part of the breast to kind of give the appearance that the nipple rotates.
Again,
up.
It fills the skin. Yeah. And then because the skin looks full initially, it makes it look early on like you didn't quote unquote need a lift.
Right.
But the skin will stretch almost instantaneously over time, and within a year or two, you will be needing
a lift. And then you get what a lot of people call bottom down, meaning that distance from the nipple down to the fold is now too long.
Yeah. And so, again, it's hard to avoid that situation. But I do think, for me, I agree with you on many points. Like the submuscular, again, dual plane, like small dual plane augmentations, quote unquote, half under the muscle, is generally a good, safe default for nearly everyone, right? Because you can handle issues where people want big implants. You can handle issues where they have thin skin. Right. You can handle issue like the pocket is very controlled, so you can handle issues with malposition and certain breast irregularities. Right. Most patients will benefit from that type of augmentation
and do well with it,
and have good results long term, as long as it's executed well. Right. It has a lot of problems if not executed well.
Sure.
Like anything.
As with anything.
So that's number one, right? And then let's move to kind of then going to what I would consider not preserve, we'll cut to that in a second,
right.
but preservation augmentation, like a subfascial augmentation. Where do you see that playing a role in patients?
Yeah, I mean, so just to define what we're talking about here. So a subfascial breast augmentation, I think, is probably the most modern technique for prepectoral or above the muscle augmentation. So the pec muscle has a thin layer of tissue on it, the fascia. And so essentially you create a pocket between the pec muscle and the fascia. And the idea is that provides some support. It shields the implant from any bacteria that might be in the breast parenchyma, therefore lowering the risk of capsular contracture, and provides more long-term coverage and stability as opposed to a true subglandular augmentation. The reason I would consider that a preservation technique, if we're going to use that terminology, is because the muscle is not disrupted.
Correct.
And so I think a lot of patients would choose that. It really depends on their lifestyle. In someone that's a competitive bodybuilder or a mega big time athlete, they may not want to manipulate the muscle at all. And so that's a great option for them. Again, in patients that have a reasonable amount of breast tissue, it's not a bad option as long as they have coverage. And people that are very thin, maybe it's not the best option.
Correct.
And so I think as we move from the procedures we're talking about one to the next, the indications kind of get smaller.
Yeah.
Like pretty much everybody is a candidate for a dual plane.
Correct.
Some people are a candidate for a subfascial augmentation. Again, very large implants. We have seen these women that come in that had these 90s implants, massive saline implants, 600, 700, 800 cc's above the muscle. They come in, their tissue is paper thin. They want a revision. It is much more dangerous and challenging to fix that problem.
Yeah, I mean, you almost can't fix it in many cases. It can be very expensive. It requires multiple stages, and then many women just don't even approach it at all. They just leave the very abnormal, very hard-looking breast implants because there's really very little solutions at that cost. Right. And again, I think I really want to emphasize for my patients that I want to make sure that this is a durable and long-lasting procedure for you, right? Again, these procedures should last you 10, 15, 20 years if done properly, and again, barring any unexpected, uncontrolled, random kind of complications. And so selection of not only the right size implant that doesn't violate your natural breast anatomy, but then the right location is very important.
It's critical.
And so, I consider that I specialize in, subfascial augmentation and whatever preservation augmentation. We've done another episode on that word. But again, not every person who comes to me is a candidate for that.
Right.
And I think all the things you said are true, right? You're going to be on the smaller size of implants, usually no full profiles. You're going to often, in some cases, need soft tissue support. So especially if you're slightly on the larger size of that implant pool, you're going to need mesh or other structure. And that's one of the things that has allowed subfascials to occur effectively is I have mesh in control.
Right, adjuncts to stave off some of the potential issues.
Yeah, that I didn't have before. And so I'd have to send those patients to submuscular. And so that is definitely some options for, again, creating a slightly more natural breast in that direction.
Right.
Depending
on the patient's
on the patient's wishes. And so, that's kind of moving in that direction.
Right.
So then let's finally talk about our experience yesterday with right? It was a long 24 hours. We went to Dr. Mark Epstein's office in New York, and we had the privilege of watching him operate and get exposure to the Motiva Preserve, which we've touched on again in terms of the concept of preservation. But what's really going on with Preserve and what did you take out of it?
So the concept of Preserve is based on an anatomic structure called the circummammary ligament. And the idea is that if you think about the breast footprint, about 1 centimeter in from that, there is a ligament that circumferentially kind of encompasses all the breast tissue and anchors it to the pec fascia. And so the idea is that by using smaller implants that respect that fascial structure and that support, we're able to get good long-term stable results in the appropriate patient with relatively minimal downtime in a way that respects the breast anatomy.
I would argue, so my hot take on this is that they kind of have it backwards. Okay. I think that one of the benefits of submuscular augmentation is that because the muscle is in sort of a separate anatomic location than the breast in some cases. You can use that to your advantage to push the limits of the breast anatomy in certain cases.
Right. And, I think, again, obviously there are limits respecting the borders of the pec, but the borders of the pec are a little bit different than the borders of the breast.
Correct. We've talked about this briefly. Like, if you choose an implant that is too wide for the patient, you know it on table because you start to see the lateral, like on the side, right? You start to see the nerves that go up to the breast.
Right.
And if you're seeing those nerves, that means you're at the lateral most extent of where the body thinks the breast is.
Right. You've kind of moved past that structure and you lose some of those adhesions and support, and the risk of things like lateral malposition over time probably goes up.
Or inferior malposition go up, right?
Yeah.
And so it's one of the problems that cause unnatural looking breasts. And so if you are seeing those, you probably have chosen an implant that is a little bit too wide. And so that's going to cause problems. And so there are anatomic structures, even at the muscular level, that have to be respected.
Sure.
So then you move up again one layer. And again, I am a little bit in disagreement with Motiva and the studies. And I'd like to go to the cadaver, the cadaver lab to kind of prove this. But again, like I really believe that the circummemory ligament is really a musculocutaneous ligament, not a fasciocutaneous ligament. And I don't want to get into the subtleties of that.
Sure.
But, I see that circummemory ligament when I do subfascials. So I'm actually under the fascial border. I very clearly see the ring around that area. And again, most of the times I preserve it or make slight modifications to it, again, to accommodate the implant.
Sure.
And so, again, that's why it allows for larger sizes. I would argue that Preservé is doing something different.
Right.
When you choose implants of the size of Preservé, the problem is that it is often smaller than the native footprint of the breast that we would choose.
Right.
So you have to place it like that. That's a different problem, right?
Yep.
Because if you choose an implant that's too small for your chest, you could also increase the rates of malposition, right? And so Preservé has allowed us to perform small implant surgery in a relatively safe way that I think was difficult with traditional techniques.
Yeah, and again, like some people might say this is history repeating itself, but I think the procedure is a bit different, because the original breast augmentations that were fraught with all these issues were subglandular, but I think that we've come back to that plane, but in a totally different way and with totally different technology.
Yeah, and the only way to do this is through consultation, guys. But like, again, you say, hey, my breast is 10 centimeters wide, right? We choose an implant in that range. But let's say you want an implant that's a little bit smaller, that's like 8.5 centimeters. Then Preservé becomes kind of the best option.
Maybe a better option.
Maybe a better option for you, right? And so I think that's where the key lies, that women who really want smaller breasts with more natural results that really are going to respect the boundaries of that anatomy without modifying it in many ways are good candidates for Preservé.
Yeah, I think they are the candidates for Preservé, right? Yeah. Because again, if you're looking for bigger implants, a more unnatural look, something that, even using the more cohesive, the more firm implants, we don't really use those in Preservé. Mm-hmm. Like we couldn't even, that's not something that we do. And so again, I think that you really, this is like everything, right? Maybe this is the engineer in me, but I see everything as a toolbox, right? If all you do is one thing, then you're not going to always apply the right tool to the right patient.
Yes, absolutely.
So if, you have to approach every patient from the entire spectrum of options, whether it's a dual plane or subfascial or Preservé or whatever it ends up being, there's a reason that we're going to choose that technique, essentially choose that tool in that person. And, again, if all you have is one thing and you're always doing that, eventually you're going to find someone that's not a good candidate for that, and then you're going to have problems.
Yeah, and I do worry about those things, right? Like, again, I do not do only subfascial, even though that's what people come to me for sometimes. I tell them, that's not really an option for you, and I'm very blessed to have patients who understand and take that expertise.
And we've said this here before too, right? Is that just because you read about something online and you show up, like, you have to be open-minded, like, especially with someone like us that does a lot of breast surgery and sees the problems. Like, you have to some degree trust our experience when we say that's not a good idea. And I'm not going to necessarily say you have to do one of these other things, but at the very least, you have to listen to the pros and cons of them and understand the limitations of those procedures.
Yeah, I mean, we're going to chop up this episode into little sound bites, and I have to again reinforce that if you only hear the part about Preservé, like, you
need to listen to the whole
listen
thing.
to the whole episode.
Well, I mean, we were talking about this. I mean, like, a lot of people are doing Preservé with things like breast lifts, and personally, like, I'm not sure that's something I would offer people for a number of reasons.
At least for now. I mean, to me, it pushes the limits of what the indication for the procedure is for, and really what it works best with.
Yeah, I mean, again, these subtle augmentations, natural looking augmentations, that's one thing. If we're completely, reconstructing the breast or reshaping the breast, maybe there's another, way to add an implant that is a better option for that.
Yeah. And I guess it's a person to person.
Yeah.
I mean, but the Preservé, I'm excited about the technology, especially when we combine it with something like our Nova protocol. We're doing these surgeries under, local anesthetic, or I don't want to say local because it's not local. It's our Nova-based analgesia protocol. And then, so there's very little anesthesia downtime. There's, very little risk associated with that from an anesthetic perspective, and then very little downtime afterwards. So again, it is, if it's something that you've been considering and you're scared of kind of larger implants, it's worth a conversation, and we're happy to answer kind of questions about it for people. Because it's exciting that this is available, and that we've come kind of full circle here.
And I think one of the big tenets in our practice and our business here is accessibility, right? And so I love that this at the very least may stimulate people to come in and talk about what the options are. And maybe they're not a good candidate for that, but at least if it opens their eyes to the possibility that they can feel better, that they get closer to what they want to see, then I think it's a very positive thing. I
mean, our mantra, right? Everyone deserves a chance to be the best version of themselves, and whatever that means for them. And so it's very neat that Motiva has pushed this technology to let us happen. So thank you everyone for joining us. I'm very excited for this. Be on the lookout for our launch of the Preservé, and come in and chat with us. See you next time.